The topic that was assigned to me is the pathology of thrombotic angiopathies, and I will spend a short period of time discussing that, especially the morphologic aspects of this, obviously. But then I will refer to the fallacy of what people and what we all have been guilty of calling in the past hypertensive nephrosclerosis. As you all know, usually the classification of the thrombotic angiopathies is based.
Yes.
So it's usually, the classification usually is based on the clinical presentation. Unfortunately, in my opinion, these presentations are just the tip of the iceberg, and we are missing most of the chronic. This is based on a relatively non-specific clinical findings as well, and therefore I think the classification of our acute thrombotic angiopathies or chronic thrombotic angiopathies on the basis of clinical presentation alone is potentially dangerous, or at least incomplete. So the acute thrombotic angiopathies are recognized by what we call endotheliosis, namely swelling of the endothelial cell and occlusion of the capillaries. Very early in the game, you will find that the capillaries are thickened and begin to have double contours, what we call remodeling of the capillary walls. Frequently, the immunofluorescence only shows some dull staining of fibrin. Very occasionally, in the acute cases, you will have actually fibrin thrombi. And the electron microscopy is usually characterized by occlusion of the capillary lumen, by swollen cells, and by platelets. Many of them, like in this case, are actually partially degranulated. In addition to that, you can have damage of the podocytes, of course, and the most important aspect is the loss of the differentiation of the endothelium of fenestra. So this is pretty non-specific for any of the acute thrombotic angiopathies, which are usually symptomatic, and particularly these signs are non-specific for the more chronic or the healed phases of these acute phases. So let me show a classic case with bad vascular disease, and here you can see the evolution of remodeled capillary walls to hypoperfusion to global sclerosis, eventually to complete disappearance of this. In the background of course, significant vascular disease. And when we see this, and especially when we also see onion skin lesions, the remodeling that occurs in the smaller arteries and arterioles, then we feel compelled by history and by tradition to call this hypertensive nephrosclerosis or nephroangiosclerosis. And this, of course, makes it then into the diagnosis, as if the high blood pressure is the cause of about 25% of patients that reach end-stage kidney disease and enter replacement therapy. So if you look at this from a slightly different perspective, this nephrosclerosis, and you look more carefully morphologically, you will see that these patients often have, like in this case, remodeling of the capillary wall with double contours. This often gets then confused with the membranoproliferative GN as opposed to the membranoproliferative pattern of injury. Notice also here the hyalinosis of the vessels and the remodeling in the arterial. And the electron microscopy in cases like this, again, shows what I already showed you, namely the loss of differentiation of the endothelium, the widening of the subendothelial space by projections in interposed pieces of cells that have been termed mesangial cells, which in my opinion are only fragments of endothelial cell, no electron dense deposits, and you can see the displaced endothelium here. Obviously, the podocytes will show variable degrees of abnormalities depending on the stage of evolution and depending on the severity of the disease. But this is basically collateral damage from the damage that occurred earlier inside these capillaries. And of course, when you look at it this way, this is no longer hypertensive nephrosclerosis. This is a chronic thrombotic angiopathy. And obviously, the finding of the causes is complicated. Here you can see a little bit of the history taken from a relatively recent review in the New England Journal of Medicine. And you can see that even though we know about this condition for almost a century, the evolution of this and the new aspects, the advances have come in the more recent decades. And again, here you see the classification that I think is more useful from a etiologic point of view and also from the point of view of the therapy. And therefore, I suggest that, like other people have done, this is not my idea, that we need a pathophysiological approach to the classification and to eventually the treatment. Complement-mediated thrombotic angiopathies can be acquired and can be genetic. Coagulation-mediated, acquired and genetic. Metabolism-associated can be acquired, like vitamin B12 deficiency, or genetic, like cobalamin abnormalities. Autoimmune-mediated, these are usually, of course, acquired. Drug-induced is often only the trigger for something that lies underneath the surface, namely one of these other either genetic or acquired conditions. And finally, the more obvious one that has been recognized for quite a while, the Shiga toxin-associated TMA, clearly exogenous, but maybe on the basis of some polymorphism or some abnormality in these other pathways, if you want. So let me show you a case. This is a 44-year-old woman that has hypertension, hyperlipidemia, progressive proteinuria for several years. Currently, the proteinuria has reached 2.5 grams. She is an African-American woman. There is no history of lower extremity edema, and so on. The laboratory shows her preserved albumin, and she has some proteinuria, of course, as you can see, 2.5 grams. The medical history is notable for asthma and polycystic ovarian syndrome. So what does the biopsy show? It shows extensive fibrosis of the parenchyma here in the cortex. Also, you can see that the vessels are very prominently shown here in this. The glomeruli look, many of them were normal, but many of them were globally sclerosed, and a few had segmental sclerosis. And obviously, this case could easily have been classified as so-called focal and segmental glomerulosclerosis. But that doesn't help us much in finding out what this patient really has. The immunofluorescence was pretty negative, except for complement, of course, C3 in the vascular walls and a little bit in the glomeruli traces. And the electron microscopy rules out, of course, a diffuse podocytopathy. This is not idiopathic focal and segmental sclerosis. And in various glomeruli, you can see damage to the endothelium, loss of fenestre, and effacement of the foot processes. So this patient has, of course, bad vascular disease, as I already pointed out, a striped type of fibrosis. You can see here in the outer medulla, the atrophy with a cast nephropathy, which of course is mimicked by the immunofluorescence in the form of polyclonal IgA hyaline casts in these stripes of atrophic tissue. So this patient has focal, global, and segmental sclerosis, most likely secondary. And of course, she has, because she is African-American, we always put this warning in that one should really look for genetic factors in a patient like this. And indeed, this patient was a compound heterozygous G1 and G2 for the ApoL1 risk alleles, something that in the past was attributed to hypertension. Hypertension attributed nephropathy in African Americans. Millions of dollars were spent in studies of this condition, only to find out later that it was a genetic, to some extent, a genetic predisposition through the mutations of the ApoL1. This is a second case that is illustrative of this process. Of this problem. 42-year-old man presents with hematuria, hemoptysis, poorly controlled hypertension. Here you have the hypertension again. The serum creatinine of 2.9 already. The serology was negative. Everything else is normal. He was on large doses of Excedrin and Motrin for the last 2 months prior to admission. And here you already saw this picture before. So this is clearly a very severe chronic damage of the vascular walls as well as of the glomeruli. The smaller arteries and arterioles have occlusive lesions. You can find different degrees of fibrin in the various circulatory areas, and you can see some occlusion of the arterioles in this glomerulus and remodeling of the capillary wall with double contours on many of the others. And here you have the higher power of this process of capillary wall remodeling. The electron microscopy confirms that there are no electron-dense deposits or paraproteins in any way. The damage to the endothelium, the widening of the subendothelial space, and the interposition of cell projections into the space. So this is a chronic thrombotic angiopathy. Upon questioning, he acknowledged chronic use of cocaine. So the cocaine, again, is the trigger here, and we attribute this to cocaine, but maybe in some of these patients, not all cocaine users develop this chronic kidney disease, but a good number of them probably do. And there may be other underlying abnormalities that facilitate this course of event in patients like this. And this is just a partial list of the drugs that are used today that can induce this. And notice here cocaine, but also other vasoconstrictors, in particular phenylephrine and other amphetamine-like products can induce or trigger the same process in those patients that are so predisposed. And we will come back to that in a second. This is a 44-year-old woman with a history of hypertension for 12 years under good control. Serum creatinine is 1.8. And the only interesting history here is that she has a history of two episodes of preeclampsia and 2 pregnancies with 1 premature birth 12 years prior. And this is often a red flag, at least in my books, and it should be in yours. The biopsy shows what again traditionally has been called hypertensive nephrosclerosis, bad vascular sclerosis, hypoperfused glomeruli, thickened capillary walls, occlusion of arterioles, as you see here with a hypoperfused glomerulus, atrophy or fibrosis of the interstitium, tubular atrophy is associated with that. And of course, the electron microscopy never fails in showing you the thickening of the capillary wall by this widening of the subendothelial space. In this particular case, there was no recent activity probably of the disease, and therefore the endothelial cells look reasonably well preserved, but the remodeling of the capillary was there. So in this patient, eventually, 12 years after the pregnancy, she was LA lupus anticoagulant positive. She had a dilute Russell Viper venom test that was positive, and antiphospholipid antibodies were demonstrated in the serum. And therefore, probably both the placental circulation was significantly affected by this, and eventually the kidney. And there is some similarity between the vascular diseases in the placenta of patients that have preeclampsia or other complications in the late pregnancy, and of course the vascular disease in the kidney. It mimics it, and the placenta obviously represents to some extent the canary in the mine shaft, if you want. And this tendency for patients to have a prothrombotic state has been recognized for quite a while. As you can see, more than 2 decades ago, this patient, but there are many other papers that show this, that women with complication in the 3rd trimester have a much higher frequency of any of these prothrombotic states, highly significant for any of them, in particular for all types. As you can see, the odds ratio is 8.2 if you take this all into account. Comparing women with 3rd trimester complications, including, of course, preeclampsia, abruptia placenta, low birth weight, and fetal demise, when you compare these complications with women that have not had any complications. And therefore, again, as I mentioned to you before, the placenta disease is the forerunner of what will happen eventually in the kidney. And this has been studied recently by people in Scandinavian countries, and you can see here that as you have more and more preeclampsia during pregnancy, as women, of course. The more preeclamptic episodes you have, the more severe or the more likely it is to develop chronic kidney disease. Notice here 20 or 30 years after the episode of preeclampsia. So there is, of course, a lag time between that, and the placenta recapitulates very early on and very quickly the disease that happens in the kidney long term. So the hypothesis is the acute and chronic thrombotic angiopathies and the underlying conditions that result in these pathologic processes in the vasculature are the cause of the vascular scarring and the cortical hypoperfusion and scarring of the kidney. And this cortical hypoperfusion and the vascular scarring in turn leads to hypertension, of course, renovascular hypertension if you want, similar in pathophysiology to the renal artery stenosis. The only thing is that stenosis here occurs intrarenally, and this leads to eventually slowly progressive parenchymal atrophy, or not so slowly, depending on the disease. Here you have two more cases I wanted to show you and share with you because they show you what one can do about this. 30-year-old pilot presents with acute kidney injury versus chronic kidney injury, hypertension, urgency, hypokalemia, and the UP to creatinine ratio of 1.7. The serologies are pending, of course. Creatinine is 2.8. He has a recent sinus infection and he uses Sudafed. Okay, a trigger for this condition, as you can already anticipate, but I will show you. The kidney shows this, namely vascular damage, severe vascular damage, hypertrophied glomeruli, the viable ones, and then, of course, remodeling of the capillary wall, as you will see in the next few slides. Here you see the details of this 30-year-old man with a number of enlarged glomeruli that look very highly abnormal, global sclerosis, and of course the vascular scarring. And this very easily is attributed to the hypertension. Look at what the trichrome in the silver shows you, extensive atrophy in this young man. The details of the glomeruli, globally sclerosed glomeruli, vascular scarring and occlusion, and of course remodeling of the capillary walls with double contours. Here you see another small artery completely occluded and the remodeling of the capillary walls. The immunofluorescence microscopy, very dramatic complement in the vasculature, of course, and this is associated with IgM, kappa, and lambda, which is the hyalinosis that you see often associated in these cases, and the fibrin, very dramatic in the vascular walls, as well in this case locally along the glomerular capillaries. The electron microscopy in this particular case was mostly hypoperfused glomeruli. You can see the wrinkling of the capillary wall, and many of the capillaries, as you see up here, had widening of the subendothelial space and remodeling of the capillary wall with swollen endothelial cells and entrapment of the red cells. So this, by history, he had exposure to pseudoephedrine, of course, excessively. But then the genetic studies showed that he had, among many other polymorphisms, a heterozygous missense variant of thrombospondin. And this is clearly a variant that is associated with atypical HUS, if you want, or thrombotic angiopathy in general. Just to remind you that we have seen also this condition triggered in some patients when they use amphetamines, Adderall for attention deficit, or when phenylephrine or pseudoephedrine is being used in the OR, phenylephrine as decongestant. We have seen these cases triggered by this. Obviously, these patients probably have, some of them at least, an underlying genetic or acquired predisposition to this. Just a reminder that cocaine also has similarities in this, and therefore they all act as a vasoconstrictor, exaggerating the damage to the glomeruli. This is the 30-year-old woman with no past medical history, admitted for an upper respiratory tract infection with anemia, thrombocytopenia, hypertension, and significant renal dysfunction. Obviously, this was easily labeled as TTP or atypical HUS, and the patient obviously was studied. She was on dialysis. The clinicians never thought that she was going to come out of dialysis, but eventually she did. This is what the biopsy shows. Extensive tubular atrophy, chronic active if you want. There's a tubular injury here. And if you look at the vasculature, swollen subendothelial space with this mucoid type of edema, if you want. Onion skin lesions, very prominent in many of the small arteries and arterioles. Of course, the tubular injury in this acute presentation. Many of the arterioles showed, again, onion skin type lesion, occlusion of the capillaries, foam cells, and remodeling, similar to what happens in the glomerular capillaries. And here you have one of these glomeruli with remodeled capillary walls, here an arteriole completely occluded by hyaline material. So the immunofluorescence, of course, very dramatic. The fibrin in the glomerula often is only very dull staining the capillary wall and not really any thrombi in particular. And the electron microscopy here in normal capillaries as comparison. Again, the subendothelial widening, the interposition of cell projections, the lack of electron-dense deposits, and again, damage of the endothelium with repair. This patient has two abnormalities, one in the C3 and one in the plasminogen. And as you can see, here you have two systems that are affected potentially by vulnerable abnormalities. The C3, the complement cascade, with dysregulation of complement, potentially leading to this. And on the other hand, the thrombosis, the thrombotic cascade. So this is what I think is necessary for us to emphasize. Obviously, we cannot get to the causes or the mechanisms of this because the morphologic appearance is pretty common to all of them, and we cannot differentiate this except potentially by history and then again by the genetic studies. And just here, I show you the complexity of two of these pathways, the complement cascade with the potential genetic abnormalities that have been associated with atypical HUS. And on the other hand, here you have the coagulation pathway abnormalities that are associated with thrombophilic states or with TTP in particular. These are the genetic abnormalities that can exist. And of course, the general population, there's a certain percentage of patients that have one or more of these abnormalities. On the other hand, you have acquired autoantibodies that interfere with the complement regulation or that interfere with the fibrinolysis or facilitate, if you want, the coagulation cascade. And finally, paraproteins can also interfere either with the complement pathway, giving you a typical HUS, or glomerulonephritis C3, for example, or under certain circumstances that could potentially also interfere with the coagulation cascade. And therefore, paraproteins also fall into the differential diagnosis of patients that present with this system. So I've constructed this little schema. Usually the thrombotic angiopathies and by extension the hypertensive nephrosclerosis are triggered very often by intercurrent infection, by drugs, by malignancy. Pregnancy can trigger this, or autoimmune disorder such as lupus or sometimes more limited forms of autoimmunity. This leads to early endothelial damage, and under normal circumstances this gets dealt with appropriately. But if you have a coagulation factor abnormality, it facilitates intravascular coagulation. You have formation of intravascular fibrin and platelet thrombi that eventually lead to thrombocytopenia and to mechanical damage of the red blood cells. That is the hallmark, of course, of the microangiopathic hemolytic anemia. This mechanical damage leads to complement activation that again gets also activated by the original endothelial injury to some extent. And if you have an abnormality in the complement regulatory proteins, this process gets exacerbated. You have an active disease where you can demonstrate consumption of C3 and the appearance in the circulation of elevated levels of the membrane attack complex, and that's one way measuring this activity of this pathway in the acute phase. This leads to additional endothelial damage, and of course, you close a vicious circle, a positive feedback loop that ends up with destroying, if not the entire kidney, part of the kidney, as you well know. Therefore, in summary, I think that the acute and chronic thrombotic angiopathies represent the structural expression of several currently well-established mechanisms of endothelial and vascular wall injury, but only a fraction of these patients will present with a recognizable and characteristic clinical picture, let's say a typical HOS or TTP. In the absence of these well-defined clinical syndromes, and I may add that this is probably the majority of patients don't have an acute presentation at any given moment, these structural features of these conditions are often misinterpreted on biopsy, confused with MPGN because of the double contour pattern, dismissed because of the clinical history as nephroangiosclerosis, and ascribed to hypertension, a predictable consequence of the kidney hypoperfusions, as physiologists have told us. And therefore, I think that a more comprehensive laboratory, functional, molecular, and genetic approach is needed to define more precisely the role of these various inherited and acquired pathogenetic factors in these various systems that I have outlined in any given patient, and that these insights should result in a more rational, preventive, and therapeutic strategy in the future. I appreciate your attention. Thank you very much.